When you live for a strong purpose, hard work isn't an option, it becomes a necessity. So when you figure out your why, whatever you're doing, why are you doing it? The how becomes very simple. How you will do it, no matter how difficult it is, you will be able to figure out how you have to do it. And no matter how much hard work you have to do for it, you do not feel that you're working hard if the purpose behind that why is very strong. You jump out of bed every morning wanting to do it. So figure out your why and let it be a strong purpose. So with that, we will start with another very, very important topic for your exam. And yes, that is the pure tone audiometry. Now, for the last few years, we've been seeing that every year there has been a question on pure tone audiometry. Audiograms are given in your exam and then you simply get baffled. So no need to get baffled. It is very, very simple. So just see, go through this with me and it will be very simple. So now we have done all the tuning fork test, and from the tuning fork test we have found out whether the hearing loss is a conductive hearing loss or a sensorineural hearing loss or a severe sensorineural hearing loss. What more are we expecting now? What next do we want to get done? Do you want to find out how much exactly is the hearing loss? Did the tuning fork tell you how much exactly is the hearing loss? It told you whether it is a conductive or a sensorineural or a severe sensorineural hearing loss. But did it exactly tell you how much is the hearing loss? We can get a little bit idea about how much is the hearing loss with the help of tuning fork. For example, if we are testing with the 256 tuning fork and if it is negative, then we say that the hearing loss is at least 15 decibel. If the tuning fork of 512 is negative, then we say that the hearing loss is at least 30 decibel. And if the tuning fork of 1024 is negative, we say that the hearing loss is around 45 decibel. But this is just an approximate idea. This is not the actual thing. But we actually want to know how much is the hearing loss. Does that help us? If we come to know whether it is a 30 decibel hearing loss, if it is a 40 decibel hearing loss, if it is a 70 decibel hearing loss, will it make a difference? How will it help us? Different conditions of the ear give rise to different amounts of hearing loss. So just by having a look at how much is the hearing loss, we can get an idea what we are expecting in the ear. For example, if there is a complete obstruction of the external auditory canal, for example, if there is wax in the ear, complete obstruction of the external auditory canal, then the maximum hearing loss can be around 30 to 40 decibel, 30 decibel to 40 decibel. Maximum it can go up to 40 decibel. So on Diwali, when you think that, okay, I am bursting a big cracker and you put cotton inside your ear, how much protection are you getting? Yes, maximum 30 to 40 decibel. Now, like the people, whenever we go in a flight, we see that the person who is standing there in front of the flight and giving the signal that yes, the flight can move now, you will see that he is wearing something in the ears. Yes, the ear muffs, ear plugs. So how much protection is that plug giving him? Yes, only around 30 to 40 decibel. So don't think that you have put that in your ear and now whatever big cracker you burst, nothing is going to happen. It will give you protection maximum how much? Around 30 to 40 decibel. And this has been a question of your exam. How much protection do ear plugs give you? Yes, so it is this much. Now, if there is a tympanic membrane perforation, so we have a tympanic membrane here. On the tympanic membrane, if there is a perforation, then the maximum hearing loss can range from 10 to 40. Maximum can be 40 decibel, but then it is a range. It varies from 10 to 40 decibel. Now, why this is a range? Yes, depending upon the site and the size of perforation. The bigger the perforation, the more will be the hearing loss. Also, how does the site influence? Now, if there is any perforation that exposes the oval and the round window at the same time, what will happen? The phase difference will be absent and that will lead to a lot of hearing loss. So, which perforation of tympanic membrane leads to maximum hearing loss of 40 decibel hearing loss? Either a very large perforation or even if it is not a very large perforation, if it is exposing both the windows at the same time, the sound will reach both the windows at the same time, it will cancel each other. So, that can also lead to 40 decibel hearing loss. Now, if there is a tympanic membrane perforation, along with that, if the ossicular chain is dislocated, then the hearing loss can again go up to 40 decibel. How does this help us? So here is a patient who has come to you and he has a tympanic membrane perforation. You get the audiogram done and you come to know that he has a 40 decibel hearing loss. Now, while operating this patient, while going for repair of the perforation, will you just go and repair the perforation and be happy, I have done my work? Or will you, or while operating, have a look at the ossicular chain also? Yes, it is a must. If the hearing loss is 40 decibel, we know that either a perforation or a perforation with ossicular discontinuity can give rise to same amount of hearing loss. So what if we just repair the perforation? If we just repair the perforation and this patient has ossicular discontinuity for which we do not do anything, will it be detrimental or will it not make a difference in the surgery, in the response after surgery? It will make. What difference will it make? Now, if there is a perforation of if there is a ossicular discontinuity, okay? So, if there is a ossicular discontinuity, but along with that, the tympanic membrane is intact. Okay, so this is what we have done, ossicular discontinuity, but we have made the tympanic membrane intact. We have left the ossicular discontinuity behind. Do you think this will give a hearing loss more than 40 or less than 40? What do you think? Yes? More than 40. Why more than 40? When there is ossicular discontinuity, the ossicular chain pathway for transmission of sound is gone. But if along with that there is a perforation, at least some sound can directly go through the perforation to the oval window. It can directly vibrate the footplate of stapes. Now what we have done is, we have closed that pathway also. The ossicular chain pathway is already gone. Now that was the additional pathway through which at least some sound was going. That also we have closed. So now what will happen? After surgery, the hearing loss will increase from 40 to 55 decibel. Are you seeing how much of a difference? And this difference is bad. It is not going towards the better side. This is going towards the worst side. Patient came to you with hearing loss. You operated him for hearing loss. And now what you have done, following surgery, you have given the patient even a more hearing loss. Is going to kill you. So, you need to know that whenever you are operating any patient and the hearing loss is around 40 decibel, you need to know that what all you can expect in this patient. Now, if there is complete fixation of the footplate of stapes, then the maximum hearing loss can be around 60 decibel. Whatever the condition is, if there is a perforation with ossicular discontinuity, no perforation, no ossicles, everything gone, but the footplate is completely fixed, or everything normal, but footplate is completely fixed. If there is complete fixation of footplate of stapes, maximum hearing loss is 60 decibel. Conductive pathway ends at footplate of stapes. So, conductive hearing loss cannot be more than 60 decibel. Now, which is the condition in which we see the footplate fixation? Yes, very good, autostenosis. So, what is the maximum conductive hearing loss in autostenosis? Yes, it can be 60 decibel. This does not mean that whenever you are seeing a patient of autostenosis, you will think of autostenosis only if it is 60 decibel hearing loss. This is complete fixation. If the fixation has just started, then it can range anywhere from maybe 30, 40, 50, 60, but yes, maximum it can go up to 60 decibel. So, now we exactly want to find out how much is the hearing loss. That we can come to know by pure tone audiometry. Now, along with that, we also want to find out which frequencies are affected. We know that ear is sensitive to a wide range of frequencies. What frequencies is the ear sensitive to? From 20 to 20,000 hertz. Yes. So, ear is sensitive from 20 to 20,000 hertz. And what are the speech frequencies? Why do we say speech frequencies? Because all from 20 to 20,000 hertz, all the frequencies are not very important to us. The most important frequencies are the frequencies that we use in speech in daily life. So what are those frequencies? They are 500, 1000 and 2000. We already know this, yes? So we want to know whether the patient has a defect in the speech frequency. We want to know if the patient has a hearing loss in the low frequency. We also want to know if the patient has a hearing loss in the high frequency. How will that help? If we know it is not speech frequency, so if it is low frequency, high frequency, is it still important? Yes. Now suppose a patient came to you with hearing loss and vertigo. Okay. So whenever hearing loss and vertigo, where do you localize the lesion? Hearing loss, It can be anywhere, but if it is associated with vertigo, we immediately know it is in the inner ear. So, okay, we have localized that it is in the inner ear. Now, in the inner ear, there can be many conditions. There can be complete dilatation of the endolymphatic system, that is the membranous labyrinth that is in Meniere's. There can be ototoxicity, drug-induced damage of the organ of Corti. There can be noise-induced damage of the organ of Corti. There can be age-related damage of the organ of Corti. So, there can be ototoxicity, noise trauma, presbycusis, there can be Meniere's. So there can be so many conditions. How do I know that this patient is having inner ear involvement because of Meniere's? He has a hearing loss. How do you know that this hearing loss is because of Meniere's? We know that in Meniere's, the earliest frequency to be affected will be which frequency? This you will have to tell me. We have done this. Yes, low frequency. Why low frequency? Because if the membranous labyrinth gets dilated, which is the first part to be dilated? Yes, the apex. So low frequency is affected first. So if this is a patient where we are suspecting Meniere's and we get the audiogram done and we see that yes, it is a low frequency hearing loss. So we know that yes, this is pointing towards Meniere's. But if in the same patient we got a high frequency hearing loss, then we will not think of Meniere's. Then we will think of maybe something else. Yes. So initially only the low frequency is affected. So yes, it is important for us to know which frequencies are also affected. So that is exactly what we find out by doing the next test that we are going to do now. That is audiometry or pure tone audiometry. Pure tone. We measure pure tones. Yes, there. So yes, the indication is we find out the type of hearing loss, whether it is a conductive hearing loss, whether it is a sensorial hearing loss, or whether it is a mixed hearing loss. What is the meaning of mixed hearing loss? Yes, we know that the pathway of hearing is conductive, then we have sensorineural. Yes, sensory, then neural. We are combining a sensorineural because by audiometry or by tuning fork, we can come to know it is sensorineural. We cannot find out whether it is sensory or neural. So, I am writing sensorineural together here. So, we can find out whether it is a conductive hearing loss, whether it is a sensorineural hearing loss, or it is both conductive plus sensorineural hearing loss. Second, we can find out the degree of hearing loss, exactly how much is the hearing loss. Yes, and we can classify it whether it is a mild, moderate, severe. How do we classify that? We will just see in some time. And the next thing we come to know is the frequency, exactly which frequency is affected, low frequency, mid frequency, that's the speech frequency, or high frequency. So, yes. What picture that we are seeing here, what we are seeing is that the person who is sitting inside the room is saying hi. Is he actually saying hi? No, this is how a audiogram is done, audiometry is done. This, the audiologist sits outside the room. The patient is made to sit in a soundproof room covered with glass, and the audiologist gives a particular frequency sound, whichever frequency sound we are testing. We test frequencies, a lot of frequencies here. So whichever frequency sound the patient is being tested for, we give a particular loudness sound and we see at how much loudness he starts hearing. The moment he starts hearing, he will raise his head. So we will know that yes, he has started hearing, we can mark it. So whatever result we get, we plot it in the form of a graph, and that graph is what we call as audiogram. Now, by seeing this test, can you get an idea that this is a subjective test or objective test? What's the meaning of subjective or objective? Subjective means subjects, patient's cooperation is required. Objective means patient's cooperation is not required. Is tuning fork test a subjective or objective test? Subjective test. Is pure tone audiometry a subjective or objective test? Again, a subjective test. So then that depends upon the intelligence of the patient. So if we talk about reliability, a more reliable test will be which one? Which is an objective test. This patient's cooperation, patient's intelligence is not required. Yes. So whatever result we get, that we plot it in the form of a graph. This graph is what we call as audiogram. So what we are seeing in the audiogram is, what we are measuring here is the frequency. Yes, so we come to know whether it is a speech frequency that is affected, or it is low frequency, or it is high frequency. So the frequencies that we test start from 125 Hz up till the 8000 Hz. The bone conduction usually we test only up till 4000 Hz, but the total frequency that we test is up till 8000 Hz. Also, what we can find out is the how much is the hearing loss. Yes, exactly how much is the hearing loss. Even in 5 and 10 decibel step, we can find out it is how much is the hearing loss. Now, what we are seeing here in the hearing loss, it starts from 0, 10, 20, and here also we have minus 10 also sometimes is given. Now, was a question asked in your exam, what is the normal threshold for hearing? So what is a normal threshold for hearing? And then the choices was 0 decibel, 40 decibel, 60 decibel, 90 decibel. So what should be the answer? The answer should be 0 decibel. So when you are marking 0 decibel here, does it mean that the patient is hearing when there is a 0 decibel sound? Yes, you are giving the sound and you are marking here. So when you mark at 0 decibel, does it mean that there was no sound and patient was hearing? No. What is the meaning of 0 decibel? 0 decibel means that the patient's hearing is exactly the same as what we consider as a normal reference hearing. Normal, absolutely normal reference hearing. It is ditto same as that. So when we say 0 decibel, it means hearing is perfect. If we have to increase the loudness 10 decibel more than what we consider as a normal for the patient to hear, then we say then we mark it as 10 decibel. So what we are marking here is the hearing loss. So then we say he has a hearing loss of 10 decibel. If we have to increase it 20 decibel for the patient to start hearing, then we say it is 20 decibel. So what we are marking here is 20 decibel or whatever decibel hearing loss. So up till 25 decibel, we consider the hearing as normal. Always, whenever we say what is normal, it is always a range. It is never one value. If somebody tells you that my child is 4 feet and how much should be his weight, or I am 5 feet, how much should be my weight normal? You do not say your weight should be 51.9990 like that. No, you do not say like that. Yes, you say that it can be anywhere between 50 to 55 like that. You give a range. So similarly, here there is a normal range of hearing. Normal range of hearing means that if I have to increase the loudness up till 25 decibel, more than what I consider as the normal reference for the patient to start hearing, I consider that yes, his hearing is in the normal range. So up till 25 decibel, we consider the hearing as normal. Beyond that, we consider there is hearing loss, which is again graded into mild, moderate, severe, moderately severe, or it is profound. Now, these grades are asked in your exam. What is mild hearing loss? What is moderate hearing loss? Now, this grading is also done in 2 systems. One is the ASHA classification, the other is the WHO classification. The one that we follow in our clinics is the ASHA classification. What is the ASHA classification? I will just tell you. For now, you just understand this, that we are doing 2 classifications. So, unless and until it is given in your exam that what is this mild hearing loss according to WHO, what is severe hearing loss according to WHO. If it is not mentioned WHO, what we are going to mark is the ASHA classification. So, first let us do the ASHA classification. What is the ASHA classification? In the ASHA classification, what you have to know, in both the classification, normal remains normal. Normal is up till 25 decibel. Up till 25 decibel, the hearing is we consider as normal. And in ASHA classification, more than 90 decibel is considered as profound. More than 90 decibel is profound. Now, this profound hearing loss was a very common question of your exams. Why? Because profound hearing loss was an indication of cochlear implantation. If there is bilateral profound hearing loss, we used to go for cochlear implantation. Now, the indication has been lowered. So, now we do it in more patients. But what we have to remember is these 2 values. Normal is 25, profound is more than 90 decibel. In between these, the ASHA classification, why we follow the ASHA classification? Because ASHA classification is more specific. It has got 4 categories in between them. Which 4 categories? Mild, moderate, moderately severe and severe. Whereas WHO classification is not very specific. It is after the normal, it has only mild, moderate, severe. So, we follow the one which is more specific, which can tell us exactly how much is the hearing loss. So, let us see what the ASHA classification is. Yes, so here we know the normal threshold is how much? Is 0 or it is 0 to 25 decibel. 0 to 25 decibel. That is why some audiograms have -10 also written there. What is the meaning of -10? -10 means that the patient's hearing is even better than what we consider as normal reference. Yes, some people might be having a little better hearing also than what we consider as a normal reference hearing. So, yes, this is what is ASHA. What is ASHA? ASHA is American Speech and Hearing Association. And Hearing Association, American Speech and Hearing Association. So yes, as I told you that up till from -10 to 25, we can consider that is the normal hearing. Up till 25 decibel, that is normal hearing. Okay, so before that, how much it is, no need to remember. Up till 25 is normal hearing. Now beyond that, 90 decibel, we know more than 90 decibel is profound hearing loss. In between these, we have to fit 4 categories: mild, moderate, moderately severe, and severe. So what we will do is at every 15 decibel, that is the simplest way to remember. 25 is normal, 90 is profound. In between these, at every 15 decibel, we will change the category of hearing loss. So now 15 decibel becomes how much? 25 plus 15, that makes it 40. So from 26 to 40 is mild. Add more 15. Yes, from 40 to 55, so 41 to 55, we change the category to moderate. 56 to 70, that again changes the category, moderately severe. And then next is severe. So what is left from 70 to in between 90? Yes, we cannot add 2 there. So from 70 to 90, it is directly a severe hearing loss. More than 91 is profound hearing loss. So have you got that? What is ASHA classification? Very simple. Yes, up till 25 decibel, it is normal. Quickly, can you tell me? Yes, what is profound hearing loss? More than 90 decibel. And at every 15 decibel, it will change. So if I tell you what is mild hearing loss, it is, yes, immediately you will think, okay, 25 plus 15. It is up till 40 decibel. What is moderate hearing loss? Yes, again 40 plus 15, that is 50. Up till 55 decibel is moderate hearing loss. So now the indication of cochlear implant has changed from a profound hearing loss to a severe hearing loss, which is more than 70 decibel hearing loss. Now let us see what the WHO classification says. As I told you that normal remains the same in both. Up till 25 decibel we consider as normal. So less than 25 decibel is considered as normal. The mild here is also the same like ASHA classification, that is up till 40 decibel, 26 to 40 decibel. After that, there are only 3 categories, and at every 20 decibel they change. Why? Because we have to fit from 40 decibel to 100 decibel, we have to fit only 3 things. So that is why we can change, no need to change it every 15, we change it at every 20. So here the moderately severe is absent, yes. So this is not very sensitive. So this is from 41 to 60. Will be moderate, then again at 20, so we are adding 20 here, yes, whereas in previous we were adding 15, we were adding 15 decibel everywhere, yes, here we are adding 20, yes, so again we add 20, that becomes 80, again from 80 we add 20, that is more than 80, that is considered as profound here. So unless and until it is asked in your exam, WHO classification, what is profound hearing loss? Yes, there it is more than 81, but otherwise if it is not mentioned WHO, what will you mark it as? More than 90 decibel. So what we are seeing is that by the audiogram, we can immediately see the graph, what has been plotted, and we can come to know whether it is mild, whether it is moderate, whether it is moderately severe, how much is the hearing loss, and then if how much is the hearing loss we know, then we can get an idea, okay, 40 decibel hearing loss, then what all am I expecting in the ear? There can be tympanic membrane perforation, there can be what else? Can it be perforation with ossicular discontinuity also 40 decibel? Yes or no? Okay, 40 decibel, can it be autostosis also? Yes or no? Yes, it can be, but maximum can be 60 decibel. If you have repaired the tympanic membrane, which had a ossicular discontinuity also, you have repaired the tympanic membrane, how much will be the hearing loss? How much will the hearing loss increase to? Yes, 55 decibel. If there is any patient who has come to you with a history of trauma of the head and you see the audiogram, it is around 50 decibel, 55 decibel. So you get an idea that what has happened in this patient. The tympanic membrane is intact. You are seeing tympanic membrane is normal and you're praying that the ossicular chain also should be normal. But you get the audiogram done and you see such a large hearing loss, 50 decibel, 55 decibel. So you know that no, what has happened? Ossicular chain has got dislocated. So that is how the degree of hearing loss helps you, and that is how the frequency helps you. So now let us get started and let us see how to read the audiogram, and you will see that it is so simple, but yes, you will have to be fully concentrated here. Yes. Whatever result we have got, we have plotted in the form of a graph. This is what is known as audiogram. Now here there are certain steps that we will follow. So what is the first step? The first step always is to see it is which ear. It is which ear. Okay, so whenever we are seeing any audiogram, we first need to know it is of the right ear or of the left ear. Yes. So how do we know that? That we know with the help of symbols. Yes. So let us see what the symbols are. The right ear is always marked in red and the left is marked in blue.
So it can be either air conduction unmasked, air conduction masked, bone conduction unmasked, and bone conduction masked. Now, what's the meaning of masked or unmasked? When I say masked and unmasked, what you do is, you later on tell me that bone conduction was masked. Was masked matlab we did not test it only. We did not test it. No, that is not the meaning of masked. Yes, what is the meaning of masked? Yes, masked means, okay, before that you need to understand, if there is any sound coming from the right side. Do we know it is coming from the right side or left side? Yes, we come to know it is coming from the right side or left side, which means are we able to localize? Yes, we are able to localize. But does it mean that if a sound that is coming from the right ear, I hear only from the right ear? No, I hear it from both the ears. Then how am I able to localize? Because if a sound is coming from the right side, that is louder in my right ear. Why is it not the same loudness in the left ear? Because while it is getting transmitted from the right ear to the left ear, what happens is that in air conduction, there is a loss of around 40 decibel. So a 50 decibel sound, if I am giving in the right ear, the same sound will go to the left ear, but in the left ear, it will be heard as how much? Only 10 decibel. Yes, only 10 decibel. So I suppose have a hearing loss of 50 decibel in the right ear. I've been given a 50 decibel sound in the right ear. Will I hear the sound from the right ear? In the right ear, I have 50 decibel hearing loss. Will I hear the sound? No, I will not hear. But I will not hear from the right ear. But will I actually hear the sound? I will hear. From which ear? From left ear. How much? Only 10 decibel. So when I'm being tested with a 50 decibel sound in the right ear and I have a 50 decibel hearing loss in the right ear, I say, I am hearing the sound. I am hearing but very little. So the examiner marks that when 50 decibel sound was given, the patient was hearing but very little. Yes? So is that a correct result? That is wrong result. Actually, in my right ear, I am not hearing. So whenever we test one ear to get the pure result, unbiased result of that particular ear, we always block the other ear so that the other ear does not contribute in the test of hearing. That is what is known as masking. We mask the other ear. How do we mask the other ear? We give a continuous sound in the other ear. That is known as a combination of all the frequencies, that is known as a white noise we give in the other ear, so that the ear is busy and it is not contributing to this ear. So this is what is known as masking, which means if I say that this result is a right ear masked air conduction, what does it mean? It means that when I was testing the air conduction of the right ear, which ear was masked? The left ear was masked. Is that clear? Okay, so now let us see what the symbols stand for. Right ear, air conduction unmasked. Unmasked, right is round. That is simple. R for right, R for round. Now for the left ear, the air conduction unmasked is a wrong. Yes. So whenever you say wrong, whenever you see wrong, what you have to remember? That wrong is always of which ear? Of left ear. Why? Because wrong cannot be right. Wrong cannot be right, no? So how can a wrong symbol be of the right ear? Wrong cannot be right. So it is always of the left ear. So air conduction masked of the left ear, what we do is, if we just remember wrong is left, we can remember the other symbol also. Just take the 4 lines of the wrong and rearrange it in the form of a square. This is the masked air conduction of the left ear. Of the right ear, the masked air conduction is a triangle. Now, in the bone conduction, very, very simple. That is, the bone conduction unmasked as well as the masked, both we can see of the right ear is opening towards the right. Are you noticing? So, you just see where it is opening. If it is opening towards the right, this is the right ear. If it is opening towards the left, this is the left ear. Is that clear? So, the moment you see, the first thing, because we want to see is, it is which ear. So, we should be able to identify by the symbols. So, you must be thinking, why know the symbols when the color code is there, right and left? In your exams, most of the time it is black. It is black. So then you think, oh my God, I should have remembered the symbols also. Yes. And symbols also separately are asked that this symbol stands for what, this stands for what. So we have to know exactly which symbols. So now let us see the audiogram. Okay. So now let us see which ear this is. Yes. So, it is which ear? Can you see this? This is the bone conduction opening towards the right. So this is the right ear. Yes, this is right ear bone conduction. And don't just see one curve and make the diagnosis that this is right ear. Always see both the curves, because many a times both the ears are given in the same audiogram. And only one curve of 1 year is given. So don't think that if 2 curves are given, one you have identified it is the right year, the other also has to be the right year, okay? So be a little patient, and if you go stepwise, there is no reason why you will mistake. So this is, okay, this is the bone conduction, so I will mark. Once I have thought something and I have decided and I have made the diagnosis, I will not leave it, I will just mark it so that I do not have to think again. So this is bone conduction of the right ear. Right ear bone conduction. The other curve, what is the other curve? Let me see. This is again round, so again right ear, and this is air conduction. Okay, so again right ear, air conduction, which means I have made the diagnosis that this is the right ear. Okay, this is the right ear that I am testing. And now the second thing, what is the second step? The second step is to see whether it is normal or not. Normal or not. If it is normal, then wonderful, very good. I do not have to think anything else. If it is abnormal, then I will have to think what is the hearing loss, whether conductive or sensorineural or mixed. Now, if it is normal, best. So, what do we know about normal? Whether it is normal or not, we know how much is the normal. Up till 25 decibel, we know that the hearing is considered as normal. Yes. So, up till 25 decibel, it is normal. So, okay. So, we know it is right ear conduction, bone conduction. Both are normal. Both are less than 25 decibels. So, yes, both are normal. So, this is a normal audiogram. Very nice. Yes. Now, let us see the other audiogram. Okay. So, what is the first step? First step was which ear? Okay. So, that is what I am going to write. Which ear? Which ear is this? This is round. Round means red. Okay. So, I will mark here. Yes. So, this is right. What is this? Air conduction. Right air conduction. Okay. So, I am looking for the other curve. Where is it? Oops. Not there. So, have I missed it, or do we don't need it? What's the meaning of air conduction? Air conduction is a measure of which pathway? Conductive plus sensory plus neural pathway. Air conduction is conductive plus sensory plus neural pathway. Now, here we are taking this together always, because by audiogram we can come to know whether it is conductive or it is sensorineural or it is mixed. Yes. The next thing what we want to see is whether it is normal or not. We have only one curve. So, let us see whether it is normal or not. Yes. Up till 25 decibel is considered as normal. Yes, so air conduction is normal. So, if air conduction is normal, it means that everything here has to be normal. Conductive also has to be normal. Sensorineural also has to be normal if the complete air conduction is normal. If there is any defect in the conductive or the sensorineural pathway, air conduction curve will not be normal. So, it means that the right ear is normal. I do not need the bone conduction curve. What extra bone conduction curve will tell me? It will also tell me bone conduction. It will tell me the sensorineural pathway, and that I also already know by the air conduction curve that yes, it is normal if the air conduction curve is normal. So, what is my diagnosis? Right ear is normal. Right ear is normal. Yes, is that clear? So, now see this. Yes, so what's the first step? First step is which ear? Yes, so which ear? I am seeing two colors here. Let me see, it is actually two or it is the same, but they have just tried to fool us. Okay, so which one do you want to see first? Let us see the red, whether it is, yes, round. So, yes, this is the right ear, air conduction. And what we are seeing is wrong. Wrong cannot be right. So, this is left. So, this is left. This is left. What? Air conduction. So, I have both the ears here. I have both the ears. I have written. Okay. So, always stepwise. Yes. So, I have written both the ears. Okay. Now, let us see. Next step is whether it is normal or not. Yes, both air conduction is normal. But only air conduction curve is given. Air conduction is given. Air conduction normal means what is normal? Air conduction normal means conductive plus sensorineural. Both are normal. Both are normal means yes, this is a normal ear. So, both ear, next step is, yes, it is normal. Both ear, normal. Is that very clear? Very good. Now, let us see this audiogram. Okay, so the first step, what is the first step? You tell me what will be the first step? Which ear? Can you figure out which ear it is? Okay, so let us see. This is opening towards right, and this is which curve? Bone conduction. So, okay, I will write here. This is right ear, bone conduction. Okay, and the other curve is, this is again round and this is again round, so right ear, and this is air conduction. So, this is again right ear, but this is air conduction. Okay, so the first step, this is which ear? So, yes, both the curves are of the right ear. I will mark this is right ear. right ear. Okay. So what's the second step? Second step is to see whether it is normal or not. How much is normal? Normal is up to 25 decibel. So is it normal? I can see one curve is above it, one curve is below it. So definitely it cannot be normal. For normal, both air conduction, bone conduction should be above it. If one curve is given, air conduction is given, that also suffices. Then it automatically tells us about the complete pathway. So even if air conduction is normal, that is fine. But here the air conduction is, the curve that is above is not the air conduction. Okay. So there is some abnormality. If both are given, both are not less than 25 decibel, means some abnormality is there. Yes. Now let us see what abnormality it is. What abnormality can it be? Yes, it can be either, we know what we are testing is either is the conductive pathway plus sensorineural pathway. So either it can be either a defect in conductive pathway, it can be a defect either in the sensorineural pathway, or it can be a defect both conductive plus sensorineural, which we call as mixed. For example, conductive pathway, tell me the defect. Tell me the site of lesion. Tell me any disease which you can think of where there will be only conductive hearing loss. Yes, there can be a tympanic membrane perforation. There can be a fluid in the middle ear, ossicular discontinuity, ossicular fixation. So many things where when the hearing loss is confined up till the footplate of stapes, that is conductive. So if there is any defect, that will lead only to conductive hearing loss. Any disease which will lead to only sensorineural hearing loss, so many of them, Meniere's, ototoxicity, presbycusis, age-related hearing loss, noise trauma, so many of them. Yes, acoustic neuroma, all of them will lead to only a sensorineural involvement. Mixed hearing loss, both? Yes, both will be in if there is any infection of the middle ear which has gone into the inner ear. For example, otitis media which has gone into the inner ear leading to labyrinthitis. So a chronic otitis media leading to labyrinthitis, or some cases of otosclerosis also, because that is at the footplate of stapes, that can involve the inner ear also. So it is not very common there, but yes, rarely it can be. Then we need to know whether it is a conductive, sensorineural mix. So now we have found out till now what it is right here, and yes, we know it is abnormal because one curve is below, one curve is above. It is abnormal. Both the curves are of the same ear. So now let us see. Now if we will start with the bone conduction curve. Now in bone conduction curve, this is normal. Bone conduction is normal. So what is normal? Sensorineural pathway is normal. Yes. Now here the air conduction is defective. Air conduction is defective, which means what? Yes, air conduction is conductive plus sensorineural pathway, and the sensorineural pathway we already know is normal. So what is the defect here? Conductive. So what's the defect? Conductive hearing loss. So what is my diagnosis? Yes, so it is not normal. What's the defect? It is a right conductive hearing loss. So when I write the diagnosis, I will write it is a right ear conductive hearing loss. And yes, we also can come to know the degree of hearing loss. That is what we saw. We can know degree of hearing loss. So how much is the degree of hearing loss? We can see that in different frequency, there is different. In 250 Hz, there is 40. Then in 500, there is 50. Again in 1000, there is around 45. So it is changing. If what we are interested in is the speech frequencies. So what we do is to find out the degree of hearing loss. How much is the hearing loss? We see the speech frequencies 500, 1000, 2000. So we take an average in the speech frequency. So let us see. In 500 is 50, 1000, 45, 50. So it is approximately how much? 50. Approximately 50 decibel hearing loss. 50 decibel hearing loss, can you tell me it is mild, moderate, moderately severe? What is it? Yes, mild is up to 40. Up till 55 is moderate. So this is moderate conductive hearing loss of the right ear. Is that clear? Yes. So when you do stepwise, you have written separate points, but when you write the diagnosis, you combine it and write it, and that becomes so simple. So, okay, now let us see the other ear. Okay, now just see this audiogram. Now, okay, the what's first step? First step is which ear? Yes, first step is which ear? Which ear? So let me see which ear. This is the right ear. Right ear, it is opening towards the right. So this is right ear bone conduction, right bone conduction. Whatever I have made the diagnosis, I will write it. Yes. And again, this is round. Round is air conduction. Again of the right ear, round is right. So right ear, air conduction. Okay. So now the next step is, so this is which ear? Right ear. This is right ear. Second step is whether it is normal or not. Okay. So let us see whether it is normal or not. How much is normal? I will make the line. I will always make the line, so that it becomes easy for me to decide. I will make the line. Yes, what we are seeing is defective. There is some abnormality. So we now need to find out whether it is a conductive or sensorineural or mixed. So now let us see. what we are seeing is that both air conduction and bone conduction of the right ear, they are running together. They are running together means that there is a defect in the common pathway. What's the common pathway? What's the common pathway for hearing? If it is going from air conduction, it is conductive. It is going first through conductive and then through sensorineural pathway. Bone conduction, when it goes through the sensorineural pathway. What is the common pathway? Common pathway we know is sensorineural. Any sound for us to be heard, it has to go through the inner ear and the nerve. Yes. So if there is a almost equal defect in both the air conduction and bone conduction, it signifies that there is a common defect in both air conduction and bone conduction, because of which the hearing loss in both air conduction and bone conduction is more or less same. So how much do we consider as that they are together, they are almost same? Up till 15 decibel we can consider it that both of them are going together, which means that if the difference between, if this air conduction and bone conduction, even if the air conduction was a little low, even if the air conduction was here, yes, and which means the difference between the air conduction and bone conduction was around 15 decibel, we consider it as that they are going together. That this is because of a defect of the common pathway. So what's the common pathway? Sensorineural pathway. So the next thing that you see here is abnormality. Whether it is abnormal or not, yes, it is abnormal. And what is abnormality? Immediately you can see whether the curves are going together or not. Yes, they are going together. Maximum at a difference of 15 decibel also. Then you can say if there is even a 15 decibel AB gap, you can say that yes, this is a common pathway defect. What is a common pathway? Sensorineural. So here in this patient, it is a sensorineural hearing loss. Sensorineural hearing loss. So what's the diagnosis? Right ear sensorineural hearing loss. How much is the hearing loss? That you can find out by the speech frequency. You can take the average of speech frequency. Yes. Now, any gross difference are you seeing in this audiogram and this audiogram? Are you seeing something which is very grossly different in this? Just a look tells you that yes, this is different from this audiogram. Yes, what you are seeing here is, here both the graphs are going together, which means that there is no AB gap or maximum 15 decibel AB gap. Whereas what you are seeing here is, there is so much of AB gap. Yes, so much of AB gap. Now here what we are seeing is, there is no AB gap. Why is there no AB gap here? Yes, because there the common pathway is affected. If the common pathway is affected, both are affected almost equally. So there is no AB gap. But here, what happens is, the AB gap is more, which means that the common pathway is, it is not only the common pathway that is affected, it is not only the sensorineural pathway that is affected, there is definitely a conductive involvement. There is definitely a conductive involvement. Yes, so whenever you see AB gap, yes, so what we were seeing first is which ear, next we were seeing whether it is normal or not. If it is abnormal, so next thing immediately you will see whether there is AB gap or not. If there is no AB gap, immediately you know common pathway defect, it is sensorineural defect. But if there is AB gap, you know that conductive involvement is there. Now conductive involvement can be only a conductive involvement, or it can be a mixed involvement where there is conductive also, sensorineural also. Yes, because of the sensorineural defect. Okay, now let's see. Yes, if there is only a sensorineural defect here, if there is in here, there is no AB gap. Yes, no AB gap, they are going together. So here, suppose in the bone conduction, the defect is around 40 decibel. In the air conduction also, the defect is around 40 decibel. So both are almost same. So which means that it is a common pathway defect. So it is a defect in the sensorineural pathway. Now if there was an additional conductive pathway defect also, so what will happen? If there is additional conductive pathway defect also, the air conduction curve is both conductive plus sensorineural. Because of sensorineural pathway defect, air conduction is up till 40 decibel. If there is an additional conductive pathway defect also, what will happen? This air conduction curve will further go down. Yes, so air conduction will be more than 15 decibel, you will see the gap. Yes, so whenever there is a gap, both of them, it means that whenever there is a gap more than 15 decibel, it means that both of the curves are not going together, which means common pathway, it is not only a common pathway. Yes, what is definitely involved? Conductive pathway is definitely involved. So now what is the thing that we need to know is it only the conductive pathway involved, or is it both conductive and sensorineural pathway that is involved? So if there is a AB gap, that is the next thing that you want to see. So if there is AB gap is present, So definitely there is a conductive hearing loss present. Now I want to see whether it is conductive only or it is mixed or it is sensorineural also. So how can I see the sensorineural pathway? That is very simple. I just need to see bone conduction curve signifies what? Bone conduction means sensorineural pathway. So next what I see is, I see the bone conduction curve. If the bone conduction curve is normal, this is normal, it means it is only a conductive hearing loss. Is that clear? Yes. So what we are seeing is, how are we going to read this? Yes. How are we going to read this? We are seeing that in this audiogram, the patient, I have diagnosed that yes, this is right here, this is also right here, this is right here bone conduction, this is right here air conduction. Air conduction. Yes. Is there AB gap? That's the next step. Whether it is normal or not. No, it is not normal. One is above, one is below. It is not normal. Yes, it is not normal. What is abnormality? Next step I saw the AB gap. AB gap is there. It means definitely conductive hearing loss is there. Whether conductive is associated with sensorineural or it is only conductive. Let me see that. So let me see this, whether sensorineural is involved also or not. So sensorineural, next I see the bone conduction curve. Bone conduction curve here is normal. So it is only a conductive hearing loss. So this is a right ear conductive hearing loss only. So you must be thinking that this we have already known, na? We can just see bone conduction is normal. So it is a conductive hearing loss. Yes. The problem arises when the curve that is given is like this. Now diagnose. Yes. So again we will go stepwise only. Which ear? Which ear is this? Again this is opening towards the left. So this is left. This is left, bone conduction. Again this is left, air conduction. That was the first step. Second, whether it is normal or not. Normal is up till 25 decibel. Is it normal? No. In this patient, it is not normal. Both the curves are affected. Yes. Third step. What is the third step? If it is abnormal, third step is you see the AB gap. Yes, you see the AB gap. AB gap present or absent. Is the AB gap present or absent here? If the AB gap was absent, that was wonderful. AB gap absent means both the curves are going together. It means it is sensorineural hearing loss. But here it is not there. Here AB gap is present. AB gap more than 15 decibel. We know one box is how much? 10 decibel, 40 to 50. This is one box. So 10, 20, 30, 10, around 20, 30. Approximately it is more than 15 decibel. So yes, we say that AB gap is present. So AB gap is present means definitely I know conductive involvement is there. Conductive hearing loss is there. So is it only conductive or there is sensorineural also? Is it conductive or mixed? So now let me see the sensorineural pathway. Let me see the bone conduction pathway. Now see the bone conduction pathway. Yes, is the bone conduction pathway normal here? No, bone conduction is also involved. So here it is both conductive plus sensorineural pathway involvement, which means it is a mixed hearing loss. Is that very clear? Have you understood this? Yes, so that is why when you go stepwise, it becomes very simple to diagnose what it is. Yes. Okay, so now to summarize, I think we have already done, but yes, quickly I will just summarize. First step is which ear, whether it is normal or not. Abnormal, what is the maximum abnormality or what all abnormality we can come to know. Whether it is sensorineural, whether it is conductive or whether it is both. If it is only sensorineural, the curves will go together, no AB gap, common pathway defect. If the AB gap is present, it means definitely conductive pathway defect is there because they are not going together. It is not the common pathway only that is affected. There is some additional defect or there is a defect of the conductive pathway. So if it is only conductive pathway, bone conduction will be normal. If there is mixed hearing loss, then bone conduction will also be defective. Is that clear? Okay, now let us come to the next audiogram. Okay, see this audiogram now. Yes, first step, which ear? Which ear? Let me see now here what we are seeing. Both the ears are given. There are so many curves here given. So whenever so many curves are given, I see that you totally get baffled. Don't get baffled. See each ear individually. See each ear as one ear separately. And when you are seeing one ear, totally make the other ear disappear as if you are not seeing anything. Yes. So now, which ear do you want to see first? Okay, right ear. Very good. Right ear. So let us see the right ear. So right ear, this is what? This is bone conduction. Okay, just by seeing one symbol, we can know it is bone conduction of the right ear. So right ear bone conduction, and this is right ear air conduction. So while I am seeing the right ear, I am just totally having anopia for the left ear. Yes, so this is the right ear that I am seeing. Next step, whether it is normal or not. What is normal? Up till 25 decibel. Okay, so yes, one curve is normal, one curve is not normal, means that there is some abnormality. What is the abnormality? For that I see the AB gap. AB gap present or not? Yes. Yes, I am seeing there is AB gap more than 15 decibel. There is a AB gap. Yes, so AB gap is present. So I write AB gap present. AB gap present means definitely conductive hearing loss is there. This I will write. Conductive is there, definitely. Now I want to see sensorineural is also there or it is only conductive. So I want to see the bone conduction curve. So see the bone conduction curve. Bone conduction curve is normal. Bone conduction curve is normal, so which means sensorineural pathway is normal. So this patient has a conductive hearing loss. So let me write the diagnosis of this patient. Right ear, conductive hearing loss. Yes, of the left ear. Left ear again we are seeing the same thing. Yes, this is the left ear. This is a normal, so there is some abnormality. There is a AB gap, so it is conductive hearing loss, and bone conduction is normal, so it is left ear also conductive hearing loss. Is that clear? So now let us see this. Yes. Now in this audiogram what we are seeing is, yes, the first step, which ear? So this is wrong. So left ear. Left ear, air conduction, bone conduction, air conduction. Yes. And this is what? This is the round. So this is right ear, right ear, right ear air conduction. Now do you see why we always mark which ear it is first? If you just mark one curve or you just try to diagnose only from the first step, then you might make a mistake. And this mistake is not acceptable in your exam. In your exam, even one mark can make a difference of so many ranks. Yes. So always go in a stepwise pattern. That is why for every audiogram I am going in a stepwise pattern. That is the way, that is the only way. So I have first step is which ear? One ear, both the ears, or one ear or both the ears. So what I am seeing is this is the left ear also, this is the right ear also. Now let us see whether it is normal or not. Okay. So I have made the curve here up to 25 decibel. Now let us read the left ear first. Yes, this is the upper curve. So let me see. Left ear air conduction is normal. It is normal. Air conduction is normal means what? Conductive is normal, sensory and plus is normal, neural is normal. If the air conduction is normal, everything is normal. Conductive is also normal, sensorineural is also normal. So I do not need a bone conduction curve here. Yes. So even if it is not given, does not matter. No problem. I know that only air conduction is given of right and left. In the left ear, I do not need a bone conduction also because air conduction will tell me everything if it is normal. Now let me see the right ear. Right ear here, is it defective? Yes or no? Yes, in the right ear, the air conduction is defective. It is defective. Just by drawing this line, I immediately see and tell that yes, it is defective. So air conduction is defective means where can be the defect? It can be either conductive or it can be sensorineural. So is it conductive or is it sensorineural? So for that, let me see the bone conduction curve. I want the bone conduction curve to see whether the sensorineural is normal or not. Where is the bone conduction curve here? No, it is not given. It is not given means I got the hearing test done for finding out what the defect is and they have missed one curve. Why they have not given one curve? If they have not given that curve, I assume that it was normal. So they have not bothered to mention it. It was normal. So when it is not given, I assume that this is normal. So if it is normal, so where is the defect? The defect is in the conductive pathway. So now tell me what is, in this patient, left ear is normal. Left ear is normal and right ear has conductive hearing loss. This was a question that was given in your exam. This was a recent question of your exam and yes, the diagnosis was in the choices. It was given right conductive hearing loss, left conductive hearing loss or sensorineural hearing loss, mixed hearing loss. All these were the choices. And what mistake you do when you see that upper curve is the left and you assume that the other curve also would be the left and you just see the AB gap. And you diagnose, okay, AB gap is there. I know AB gap is there. It means it is a conductive hearing loss. And you mark the diagnosis as left ear conductive hearing loss. Why? Because the upper curve you have seen is of the left ear. So you assume that the other curve also would be of the left ear. Is that clear? So here, see always which ear, whether it is one ear or both the ears. Now let us see the other curve. Yes. So first step. Okay, both the ears are given. So now let us see how simple it becomes now. Yes. So both the ears are given. I will see the right ear first. Right ear. Okay, right ear. This is the right ear bone conduction and right ear air conduction. So these are right ear. I am going to see first air conduction and right ear bone conduction. Yes. Right ear bone conduction. Yes. Whether it is normal or not. What I am seeing is partly normal, partly abnormal. Which are the frequencies which are normal? Yes, the low frequencies are normal. In the high frequencies, see in the high frequencies in 2000, 4000, 8000, 6000, I have to increase the loudness to 50, 60, 70, 80 for the patient to hear. So this is what? This is a high frequency that is involved. Okay, high frequency hearing loss. And what is this? Whether it is AB gap or not. Immediately I see the curve, I see no AB gap. No AB gap is wonderful. Yes, it is sensorineural hearing loss. So it is right high frequency sensorineural hearing loss. Let me see the left ear. Left ear is also, I can see, following the same pattern. There is high frequency hearing loss. There is no AB gap. So there is sensorineural hearing loss. So left also high frequency sensorineural hearing loss. Is that clear? I can write bilateral high frequency sensorineural hearing loss. So just a look at the audiogram. Which ear? AB gap there or not? No. Which frequencies? High frequency. Can you see that when the high frequency is affected, what becomes the slope of the audiogram? Yes, it becomes a downsloping. It becomes a downsloping audiogram. So many a times in your exam, it is just given, patient has a downsloping audiogram. Downsloping audiogram immediately tells you that it is what frequency affected? High frequency affected. So then what are the conditions that you will think when it is high frequency affected? Yes, high frequency is affected in ototoxicity, in noise trauma, in presbycusis. We will write that. But for now, you just understand this. Can this be mean ears? No, this cannot be mean ears. Why not? In mean ears, what is affected? Low frequency is affected. Yes. So this can be any of whatever is given in the choice. You can mark for high frequency hearing loss. Let us see the next audiogram. Yes, here. What we are seeing is again first which ear? This is the right ear. Right ear air conduction. Right ear air conduction, and this is the other ear. Okay, both the ears are given. I will see first one ear. Let me see the right ear first. So this is right ear. Whether it is normal or not? It is normal. Air conduction in the right ear is normal. Air conduction is normal. So conductive plus sensorineural normal means the right ear is perfect. Right ear normal. Right ear normal. Let us see the left ear. Left ear. Yes, left ear. Air conduction, bone conduction going together. There is no AB gap. No AB gap means in the left ear there is a sensorineural hearing loss. That I know. Yes. It is below the normal curve. So this is hearing loss. What is the hearing loss? Both the curves going together. No AB gap. So there is a sensorineural hearing loss in the left ear. Okay. And what I am seeing, it is partly below, partly above. So what is the frequency here? In which frequency do I have to increase the loudness so much? The low frequency. This patient has a low frequency hearing loss. In which ear? In the left ear. So yes. So it is low frequency sensorineural hearing loss. Low frequency. Yes, left sensorineural hearing loss in the low frequency. Can this be mean ears? Yes or no? Yes, it can be mean ears. And instead of giving that in mean ears low frequency is affected, what is given sometimes in mean ears? There is an upsloping audiogram. Is that true? Are you seeing that the slope is upsloping when it is a low frequency hearing loss? Yes or no? Yes. And that is very easy to remember. Downsloping is low frequency or upsloping is low frequency. Now just remember it like this. If the slope in front of you is going up, where are you standing? You are standing low, which means it is a low frequency hearing loss. If the slope in front of you is going down, means where are you standing? You are standing up. So this is high frequency. That is just a mnemonic how you can remember. Now, yes, see this, what we are seeing, individual ear, which ear we can make out. It is both the right ear as well as the left ear. Next step, I will see one ear first. I will see whether it is normal or not. What I am seeing is that here, let me see individual ear first. Let me first see the, this is the left ear cross and like this. So this is left ear. Left ear, is it normal or not? That is the first step, no? Even if they are going together, it has to be normal or not. I cannot just say that they are going together, so there is a sensorineural affection. Yes, only if it is abnormal, then I will see whether it is going together or it is, there is a AB gap. Otherwise, if it is normal, then no need to see, it is normal. So let me see. Yes, it is more or less normal except for one frequency where this is going below normal, and that is what frequency? 4000 Hertz. 4000 Hertz, there is a dip. So this typical dip in the 4000 Hertz, and yes, there is in this dip also, when it is going down also, I am seeing that they are going together. So there is a sensorineural hearing loss. In both bilateral, there is a dip at 4000 Hertz. sensorineural hearing loss, and there is a dip at 4000 Hertz specifically, which is known as acoustic dip. And this is the first change that we see in noise-induced hearing loss, in noise trauma. Later on, what happens in noise trauma? All the high frequencies get affected. This is the first change. And when all the high frequencies get affected, then you get a uniformly downsloping audiogram. Yes, here first, which here? I can see it is opening towards the left and left. So it is left bone conduction, left air conduction, normal or not? Yes, there is abnormality. What abnormality? AB gap. AB gap present means conductive hearing loss. I have written. Conductive is there. Now, whether there is associated sensorineural or not, see the bone conduction. Bone conduction here, normal. So, only conductive hearing loss. Diagnosis, left ear, conductive hearing loss. Yes? Additional finding what I am seeing here is that in the bone conduction curve, I can see specifically a dip at 2000 Hertz. Bone conduction is normal, but still there is a typical dip that is seen at 2000 Hertz. So this dip in bone conduction, dip in bone conduction at 2000 Hertz, still it is less than 25 decibel. Yes, maximum going up till 20 decibel. This is what is known as Carhart's notch. Why this Carhart's notch is seen, this we'll see later on. This is a feature of autosclerosis. This is a feature of autosclerosis. Why it is seen in autosclerosis, we'll see when we see the pathology of autosclerosis. For now, what you have to remember is just by seeing a dip at the bone conduction 2000 Hertz, you cannot diagnose that this is autosclerosis. Autosclerosis means fixation of foot plate, means primarily that will be what? Hearing loss. Conductive hearing loss. So, you have to see whether AB gap is there or not. So yes, that was the first thing that we saw. AB gap is there. So we have said that it is conductive hearing loss. Now to see whether in the conductive hearing loss, whether it is the ossicular discontinuity fixation, most common fixation is autosclerosis. Now what we are seeing is there is an additional dip at the 2000 Hertz. So this is suggestive of autosclerosis. In all cases of autosclerosis, you might not see the dip, but in all cases of autosclerosis, you will see the AB gap. Is that clear? So for diagnosis of autosclerosis, don't just go to see the Carhart's notch. See both AB gap plus there has to be a dip in both the in the bone conduction curve at 2000 Hertz. Yes. So dip at 4000 Hertz is noise trauma. Dip at 2000 Hertz is autosclerosis. That is Carhart's notch. So now let us first quickly write the steps for diagnosing PTA. Yes, the steps are which ear first, whether it is the left ear, whether it is the right ear, or whether it is both ear. Whether it is both ear. Second step, whether it is normal or not. Yes, so if it is normal, wonderful. If it is abnormal, yes, then you will go for the next step. What's the next step? See the AB gap. Yes, if the AB gap is absent, it means sensorineural hearing loss. Means both the curves are going together, or AB gap maximum up till 15 decibel. We consider it as normal AB gap, means both the curves are going together. So sensorineural hearing loss. Yes. So if the AB gap is more than 15 decibel, then we consider that it cannot be because of common pathway defect. So now whether it is definitely a conductive hearing loss. Yes. So now we want to see whether the bone conduction. If the bone conduction is normal, then I say that bone conduction is normal, so sensorineural pathway is normal. So AB gap means we know conductive hearing loss is there. So this is only conductive hearing loss. If the bone conduction is also defective, then definitely I know it is conductive hearing loss already plus sensorineural, so it is mixed hearing loss. Now, if you are seeing that there is a sensorineural hearing loss, see the slope also. How can be the slope? Yes, it can be either a flat or it can be downsloping. This is downsloping. Can you tell me downsloping will be seen in downsloping means the slope in front of you is down. Where are you standing? High. So this is high frequency. High frequency will be seen in three things: in noise-induced hearing loss, or in ototoxicity, or in presbycusis. Okay, what is this we are seeing? We are seeing upsloping. The slope in front of you is upsloping. So upsloping means it is low frequency. Upsloping, or you can also call rising. Yes, so it means it is low frequency. Low frequency suggests that this can be mean years. Yes, a typical dip at 4000 Hertz. At 4000 Hertz tells you that this can be noise induced. And U, what is this U shape? Can you tell me this? This U is also known as cookie bite. Cookie bite. Take a cookie, bite it. What is the shape? U. This is also known as trough shape. When will this be seen? What gives a U shape? Yes. Can we, U shape means, let me draw it. U. I've drawn the U like this. Yes, U. So, can you tell me U means what? U means that at low frequency patient is hearing good 20 decibel, 30 decibel. High frequency again the patient is hearing good, yes, 10 decibel, 20 decibel. But in the mid frequency, in the speech frequency, see, I have to increase the loudness so much for the patient to hear. So this U shape means it is a mid frequency hearing loss. U shape means it is speech frequency or it is mid frequency hearing loss. Mid frequency hearing loss. This is seen in congenital sensorineural hearing loss. Congenital sensorineural hearing loss. And if there is a AB gap, along with there is Carhart's notch dip at 2000 Hertz in the bone conduction, if there is a AB gap, plus there is, along with AB gap, there is a dip at 2000 Hertz in bone conduction, then this is what is known as Carhart's notch. Carhart's notch, and that is a diagnosis for otosclerosis. Okay, so now what you are going to do is you are going to keep your pen down. Yes, and I am going to give you a rapid fire round. Let me see how many answers. Okay, so your first question starts now. Okay, so see this audiogram? Yes, quickly. Always in orderly fashion. Don't try to skip. Don't be in a hurry. Yes, quickly tell me which year? Yes, right here. Diagnosis? Normal. Very good. Next. Which year? Right here. Normal, not normal. Yes. Only one curve given, but air conduction given. Still, can you tell me it is normal or not? Yes or no? Yes. Air conduction given. So, both conductive, sensory, normal. Yes, normal. Normal right here. Next. Which year? 1 year, both years. Yes. Both years. Both years. Normal, not normal. Yes, both years normal, but only both years air conduction given. Is it still okay? Yes, air conduction given means conductive, sensory, everything normal, normal. Next, which year? Yes, right here. Right here, normal, not normal. Yes, at least by seeing that you can know it is abnormal. One curve up, one curve below. Okay, next step, AB gap, yes or no? Yes, the moment you see this, you know it is right here. There is so much of AB gap, abnormal. See the bone conduction. Bone conduction is normal. So, AB gap is there. Definitely that tells you it is a conductive hearing loss. See the bone conduction? Normal. So, diagnosis? Yes. It is a right ear conductive hearing loss. Bone conduction is normal. So, it is only a conductive hearing loss. Next. Yes. Right ear, left ear? Right ear. Right ear. Normal, not normal? Abnormal. Yes. Next step. AB gap. Present, not present? AB gap, absent. So, diagnosis means both the curves are together. Common pathway defect. What is that? Sensorineural hearing loss. Yes. Can you tell me what frequency is affected here? What frequency? It is upsloping or downsloping? Downsloping. This is the audiogram of a 70-year-old male. Tell me the diagnosis. Presbycusis. This is the audiogram of a musician. Noise-induced hearing loss. This is the audiogram of a patient of septicemia who was given IV kanamycin. Yes, ototoxicity. So, whatever is given in the choice, whatever is given in the question, accordingly you can mark. All the three will have high frequency hearing loss. Yes. Which year? Which year? Quickly a look at both the curves. Yes. Which year? Yes. Left ear. Normal, not normal? Abnormal. Yes. Next you see AB gap, yes or no? Yes. What is the abnormality? AB gap is also there and bone conduction also defective. AB gap is there means definitely conductive hearing loss. Bone conduction is also defective. So, mixed hearing loss. Okay. Yes, here. Which ear? Both the ears. Both the ears. Tell me about the right ear first. Yes, right ear. Normal, not normal? Normal, not normal. Definitely abnormal. I can see the AB gap. So much of AB gap. It has to be abnormal. Yes, so much of AB gap, so conductive hearing loss is there. Conductive hearing loss is there. Whether it is only conductive or not, bone conduction normal. So only conductive hearing loss. Both the ears, bilateral conductive hearing loss. Very good. Next, which ear? Yes, left ear, right ear, both ears. Yes, left ear, tell me about left ear. Left ear normal, not normal? Left ear normal. Air conduction normal? Normal. Right ear normal, not normal? Air conduction defective, bone conduction not given, assume normal. Yes, so this is left, this is right, conductive hearing loss. Left ear is normal, right ear is defective. Yes, what we can see here is that both sensorineural hearing loss, we can see both the curves are going together in both the ears. And which frequency affected? High frequency. Slope, the moment you see it is bilateral sensorineural, high frequency. Yes. What all can it be? Ototoxicity, noise trauma, presbycusis. Yes. Here you can see which ear? Both the ears, right ear normal. Left ear low frequency. Yes. Sensorineural hearing loss. Diagnosis, most probable, mean ears. Yes. Here, what are you seeing? A dip at 4000 Hz. Diagnosis, noise trauma. Here, yes, what you are seeing is both ears, AB gap, bone conduction normal, bilateral, conductive hearing loss. Which ear? Left ear, AB gap present, bone conduction normal. So left, conductive hearing loss. Along with that, yes, a dip at 2000 Hz. Yes, so that is Cahardt's knot. Okay, so now just think and tell me. When you see audiogram, what are you expected to know? Yes, first is which ear, what is the diagnosis, whether it is conductive or a sensorineural or a mixed hearing loss. So by seeing audiogram, can you know now it is which ear? Yes, do you know all the symbols they are asked in your exams? Yes, yes. Do you know whether it is a normal or abnormal? Yes, by the 25 decibel. We know it is normal, abnormal, how much range also it is, mild, moderate, severe, moderately severe, we know that. Do you know whether the hearing loss is a conductive hearing loss or a sensorineural hearing loss? Yes or no? Conductive hearing loss, there will be AB gap, bone conduction, normal. Sensorineural hearing loss, no AB gap. Abnormal curve, no AB gap. And mixed hearing loss, both conductive plus sensorineural. So now whenever you get an audiogram, will you be able to find out which audiogram, which ear it is? Yes, the symbols are given in your exam. You need to know each and every symbol individually. Will you be able to find out whether it is normal or abnormal curve? Yes, if it is abnormal, will you be able to diagnose whether there is a conductive hearing loss or not? Yes, if you see the air bone gap and the bone conduction is normal. If you see the air bone gap, along with that there is abnormality of the bone conduction curve, what hearing loss? Mixed hearing loss. If no airborne gap, if it is abnormal and no airborne gap or maximum 15 decibel airborne gap, that is sensorineural, means both the curves are going together, common pathway defect. So this is all that we need to know in the audiogram. We need to know it is which ear, we need to know whether it is normal or not. If it is abnormal, there can be only three things that can be abnormal. Only three abnormalities we can find out, whether it is conductive, whether it is sensorineural, or it is a mixed hearing loss, conductive plus sensorineural. That is so simple. No abnormal, but no AB gap, sensorineural. Abnormal and AB gap with bone conduction normal, that is conductive hearing loss. Abnormal with AB gap with bone conduction also abnormal, then that is mixed hearing loss. That is it. If you know this much and if you go by this approach, there is no reason why any question of audiometry you will make a mistake. So always follow this pattern. Take 2 minutes because this is some question which is very simple. This will give you an edge over the others, and this is so simple. Only 3-4 things you need to know, and when you practice it, it becomes a reflex. It becomes so simple. How much time? Yes, in each and every audiogram now, we started from the beginning and we took some time, good number of time, because I wanted that your steps should be permanent. Your steps should be, you should be clear in your mind that this is the only way. But when you do it again and again, it becomes very simple, and be it pre-final, be it your entrance exam, it is very likely that every pre-final will get audiogram in the Viva, and it is very likely that every year in some or the other exam, you will definitely get a audiometry based question. So I hope you have done it. Now it's time for you to open the questions and do them.